And I will share a screen and pull up your case for you.
Okay, sounds good. Yeah, I have my little notes here too. Okay, perfect.
All
All
right.
right. So this patient is a 38-year-old male. He's been seen several times on and off at our clinic. Usually he comes in about every 6 months or so with these venous stasis ulcers on his ankles. And he usually comes in because, I mean, it's a chronic thing. I don't think they've ever healed up, but he just comes in because they are so painful and they're usually weeping and infected by then. So basically what we've been doing is just treating with antibiotics and then trying to refer to wound care. This patient is pretty difficult to get a hold of, and he really gets lost to follow up a lot of the times. And really his only risk factors, he is a smoker. Other than that, he's pretty young, so he doesn't really have any other like chronic diseases or anything like that going on. But he actually saw one of our other providers the last time that he came in, and we ended up calling the hot foot hotline. So he had a pretty moderate, like a deep ulcer. There wasn't, I don't think there was any exposed bone or anything like that, but it was definitely weeping, like this yellowy, cloudy fluid. Pulses were pretty difficult to palpate. I don't even think that we could palpate them. So we ended up after consulting the hot foot hotline, they told us to basically send a vascular, which he did get in to see Dr. Mintz. And then we referred him to wound care, but I just got a notice that he has been lost to follow up and nobody can get a hold of him. So I don't really know what's going on with his wounds from this point. Yeah, you can go ahead and go down. There was definitely a lot of erythema. I don't think he ever had a temperature. Whenever he was in here that day, he actually left while we were on the phone with the hotline, and I believe he went to the ER and ended up getting antibiotics. But I don't know if he ever took those or what. I'm sure Dr. Mintz could kind of chime in here too and kind of give her point of what she did with him. But basically, my question is there anything that we should be doing as far as our wound care, since he gets lost to follow up a lot and he does not follow up with wound care or anything like that? So is there anything that we could be doing in the clinic to kind of keep those wounds covered?
So this is great. Thank you. That was a great presentation, Kristen. And this is, where some of our vascular stuff kind of crosses over. So this is a venous patient. So when you were trying to fill out the form, this form is probably more geared towards like diabetic and arterial ulcer. So that's why, well, I know we were looking through it. You're like, moderate, but it doesn't really make sense because it's a huge wound, but so it's not mild, but it's not. So I think those Wi-Fi criteria don't necessarily apply. Wi-Fi is the fancy term for the staging system that we use as vascular surgeons when we have wounds. And that's what the questions are geared towards so that we can eventually like actually report on findings. It's just easier for us, just in case you're wondering why it looks the way it does. But anyways, this guy looked like a pretty standard, just bad venous stasis. When I examined him, it was probably hard to feel the pulses because of his edema. And his feet, I was able to sink down and eventually feel the pulse. And I also checked signals though, and they were fine. I can't remember. I don't have his chart pulled up for me right now. I can't remember if he had a DVT in the past and that's how he ended up like with a post-thrombotic syndrome. Or if I can't, do you remember, Kristen?
I don't remember. I don't think that was in his chart. So either it got missed or I don't know,
Like I
honestly.
would have asked about it for sure. And I can maybe pull that up in a bit, but for whatever reason, he has these chronic stasis ulcers. And I just think one of the things that I very much noted was that, he had a toddler and a baby that they carted over from Green Bank in the clinic when I was examining him. So I think that's might be the source of why he's so hard to keep on top of things. He told me that we had a discussion because I felt that really he just needs wound care. Like he just needs some debridement of it to get it to close up. Like he needs routine debridement and he needs good compression. And I told him, that PMH is supposed to have some sort of wound care because that was really the only place he would agree to go to. And so I don't know what happened from there. And I looked through the records and I saw he didn't come back. And I wouldn't see him routinely because this is more of a wound care compression kind of issue, not necessarily a vascular issue. Unless he required some intervention to close down his veins. But at this point, I think we were just trying to get that. And I think you gave him some PO antibiotics. I don't know if he actually took them or not. Anyways, I'm gonna kick it though to Dr. Diamond to talk a little bit about maybe, is there something that you guys could do or something we could set up so you guys could do that wound care?
First of all, is there any photos of this wound?
I'm gonna dig up the chart right now and I can show everyone.
Because certainly, what I would say first and foremost that you could think about doing with any kind of wound, a lot of times the pain is related to the uncontrolled drainage. When drainage sits on the skin, it's going to hurt. So if he's leaving it, you don't really want him leaving it open to air. I'm not sure what kind of insurance he has. Certainly things that you might have accessible in your clinic when this painful is to give them, to start them on some kind of non-adherent later, like a Xeroform. We typically will use on these painful venous ulcers is Xeroform and then super absorbent dressings. So, any wound care center would kind of order that through DME. Sometimes you can order those kind of things directly through like a Medline or a DME suppliers. There's online forms. I'm suspicious that it could be an inflammatory ulcer possibly, just given the type of pain that you're describing. Any IVDU use in the patient at all, or just given his age and severe ulcers?
He does have a substance abuse history. I believe he's on Suboxone.
Okay. So usually when I see that young at age with these kind of painful ulcers, my suspicion is he probably has pyoderma gangrenosum associated with, or an inflammatory ulcer associated with that. And they'll be characteristically heavy draining wounds. They'll be malodorous. They'll be extremely painful. They can look nasty. So they'll have a lot of multicolored fibrotic tissue on the wound. And many times they're, that's a little bit better. They can look like they're infected all the time, but sometimes they're not.
Can you see the
looking at
picture
his
I just
wound,
pulled up?
he's very, yeah, I can. So here so I wouldn't say, like right now, it'd be hard to say whether that is or is not an inflammatory ulcer. We would probably debride it and see if it got bigger. He's markedly excoriated around there, which tells me he's got a lot of drainage that's uncontrolled. So I would put a moderate to high potency steroid cream around that area to calm it down. You could try clobetasol, triamcinolone, or betamethasone. We use those three depending on which his insurance will cover. Some of the Medicaid prefers the triamcinolone, but any of those like daily around there and some absorbency. But yeah, a lot of that on the surface is just the biofilm and stuff, and that could be debrided often with wound care if he would follow. But to get some of that painful redness out, I would go with, that's an inflammatory and excoriated reaction, would be like a steroid cream. And maybe that's something he could kind of do at home. And even if it was ABDs, even if he had to double up some ABDs or something to handle the dressing. But that's showing clearly he's probably got a lot more drainage, and the compression will help if he wear any compression to kind of reduce the swelling and reduce the drainage.
So just from your questions, he has Aetna Better Care, Aetna Health Better Care.
Okay. So that's Medicaid, so that becomes tough. A lot of times they're not going to get a whole lot covered. There is a company called Adapt Health that some of our wound nurses have found that will supply a dressing called Zetuvit, Zetuvit. If you download their form online, you can kind of send that in, and which is a super absorbent dressing that locks it away. That might be helpful, or a lot of times on these patients, if they don't have anything covered, we'll try to use some Xeroform and ABDs. You kind of got to make do. with his history of IBDU, he could become inflammatory just with as small as it is and as painful. Certainly Dr. Mintz could comment. I've had some patients have some perforators, the issues underneath there, particularly in the lateral medial ankle area, that also can be very painful. And if he had a former post-traumatic situation, but again, that's probably a lack of follow-up. I think to kind of help his pain, I would kind of try to get him using a steroid cream and something absorbent and compression. That at least gets you through, because a lot of that redness, the redness from inflammation is going to, where it's going to differentiate from an infection is it may feel slightly warm to normal skin temperature, and it won't streak. It'll kind of be in that peri-wound area. So whereas cellulitis, you're going to see the streaking and things like that. So is it wrong to try? But if you're giving antibiotics, and if the antibiotics aren't going to heal that wound, it'll take care of any infection, but it actually is not going to close that wound. If that helps at all.
Just update. So he was at the Somersville Wound Care Center in 2022. He worked with them for a year with Una boots. Bilateral lower extremity wounds seem to have improved, but then they reopened. So he says he's had these for 4 years. He was getting
Probably
them until July 2022. No DVT, no history of DVT or anything like that.
Me personally, I wouldn't Una boot this. It's more full thickness. It needs to breed it unless it's inflammatory, but it's hard to tell until you did it one time and see if it got worse. He certainly would be at risk for that given how long he's had venous leg ulcers that have been present for 6 months or longer, have a higher incidence of becoming an inflammatory wound, which limits your ability to debride. But his wound could also use, we use Santal, which is a prescriptive ointment. For Medicaid patients, Smith and Nephew has a patient assistance program. So just like you can get free medications for some of your patients for, say, their Eliquis, if you go to the Smith and Nephew site, they do have a form. And we've never had one patient denied yet to get free Santal that has West Virginia Medicaid. That would be another ointment that would topically treat the wound surface, has some slight pain reducing properties, and you can still use the steroid cream around it.
Okay, so plan for patient then, if he actually shows up, would be steroid cream around the wound for the inflammation, Santal, getting in touch with Smith and Nephew.
I would use, if that's too much for you to do, the other option on the wound is to prescribe them Bactroban and Neosporin, have them mix it together and put it directly on the wound.
So he's been doing that. So I have here that he was treating with Neosporin and gauze at home.
Well, that's not going to, the gauze isn't going to be absorbent. I mean, Bactroban and Neosporin, like I said, Santal would be my ideal and the steroid around the outside. But sometimes if they can't and they're lost to follow-up and, if you can't go to all that, not being a wound center and getting the Santal and measuring the wound and doing all that, it's going to take time for that to heal, but he's going to need to do it every day, keep it covered, and you got to handle the drainage or he's always going to look like that.
So you have the info on the drainage dressings that she's recommending, Kristen. My internet kind of went in and out, so I didn't hear it all.
Yeah, I wrote it all down. So
great. Okay. So if we get in touch with him and then, hopefully, I think I ordered some compression stockings for him. My recommendations were, you know what, I got in touch with St. Joe's as well, but I think he wanted PMH. I did order a venous insufficiency study, which he did not show up for. And then I agreed with the antibiotics. That's right. I think I got in touch. I told him to get in touch with Kristen again to get that prescription because of the redness and the pain. And I also got him connected with his smoking cessation services, which I'm sure he knows shit as well. But let me see here. Scheduled for November 8th, I guess, is the soonest one. So that's everything I have here. He showed the appointment at St. Joe's. And that's Dr. Meeser might be able to, offer some stuff there, but this is a 38-year-old that has a toddler and a child and has to travel a distance and has these chronic wounds for the last 4 years.
Dr. Diamond, do you still advocate adding a topical lidocaine gel to the Bactroban triple antibiotic ointment for pain control directly on the wound?
You can. For any open wound, lidocaine can be added. It does not diminish the properties. It could be added to Santal, it could be added to honey. So any of those, even Bactine spray, you can spray on the wound. All of that is compatible as well. Thanks, Catherine. And that they can buy over the counter even, so.
Thank you all so much, and thank you for the case presentation, Kristen, and Dr. Mintz as well. Any other comments, questions about this case or recommendations? And thank you, Dr. Diamond, for all those recommendations and the feedback on that. Kristen, did you have any other questions about your case you'd like addressed or you wanted to have covered? Oh, I see you chatted in.
Yeah, sorry, my unmute wasn't working. No, I think she covered it all. That's really helpful for us to have a starting point for that. So thank you.
Excellent.
And feel free to, I don't know if you guys are on Epic, you can secure chat me or send me a staff message anytime you need help with something, certainly.
You can always connect them through the Hot Foot hotline. That's our best option because they're not in Epic.
And you're more than welcome to do a follow-up case on this patient as well, Kristen, if you'd like. You can always bring him back and do a follow-up with the group. Alrighty, well, without further ado, we'll go ahead and transition into the didactic portion. Dr. Bozia, I made you co-host, so you should be able to share screen anytime you'd like, but I'll turn things over to you to get started on that. Thank you.
Great, thank you very much. So I'm really excited to be part of this collaboration. I feel like, you know, trying to tie together providers and get ahead of what I call the curve, right? Because as a doctor here at Ruby and, you know, being the only level 1 trauma hospital in the state, we get a lot of what they call all the time transfers for higher level care. But usually by the time I see them, ooh, my lights just went out, you know, to be evaluated on the hospital side as a consult, you know, now I'm already having a conversation about doing surgery or something like that. It's never about, well, how's your hemoglobin A1C and, you know, lifestyle issues and things like that. So certainly, you know, being able to come up with a plan to get ahead of the curve, I think is great. And then also just to, you know, collaborate and build referral networks and just a network of specialists, I think is a fantastic idea. So I'm just going to move for a second so my exam room lights will turn back on. Hold on a minute. Happens all the time. I walk in all the time on my patients sitting in the pitch black and they're too afraid to get out of the exam chair because they might fall. So I'm trying to fix that. So I'm going to go ahead and share my screen. And my topic is basically about diabetes, but you'll notice that, you know, a lot of people think, okay, diabetes, you know, my feet, my legs, but really diabetes is a head to toe issue. And as you guys know, I mean, it affects the eyes, it affects the kidneys, it affects a lot of things. But I'm primarily just going to focus on this. Let me get it up here. Okay. Move that over. Can everyone see that okay?
Yes, we can.
Yes, ma'am.
Okay, perfect. And then feel free, you can interject at any time, ask me questions. Okay. Need to figure out how to move this up so I can read it. Okay. So this is sort of my overview for today's talk. You know, state of West Virginia can be challenging. We're #1 in a lot of things, unfortunately not in college football right now. But we are #1 and #2 in a lot of other things. Also just overview of just the state of disability in the state itself, comorbidities, diabetes by the numbers, lower extremity amputation overview, things that we talk to about our patients regarding diabetic foot education, things that we include in our exams, different ways that we classify wounds, Some of the newer things and toys that we use here at Ruby and probably at some other hospitals as well. Things to think about when you're considering a referral to one of our specialists. The importance of integrated care teams, and where to find WV podiatry currently. Stopped advancing for me. Oh, there we go. Okay. So this is sort of, in a way, a little bit, it can be a little bit challenging. We are actually currently #1 in the nation in obesity. 40% of our population is considered obese, so that would be greater than 30 BMI. Previously 37.3. We beat out Mississippi in that one. Mississippi used to be #1 for quite a while. Second highest per capita obese or overweight. First in the nation for cardiovascular disease. We are highest per capita rate of diabetes in the United States at 15.2. First in the nation for poor physical health, poor mental health, activity limitation. According to the current status, almost 30% of our population has no leisure activity or exercise. We are #1 in the nation for arthritis. And I believe some of this has to do with our history of, really manual labor type jobs where they're really, working their bodies hard to be able to afford and pay for their families and things like that. We are second highest in the United States for tobacco use. #1 is still currently the state of North Carolina, which I think also has to do with their historic tobacco growing. This gives you an idea of what the percent and what it looks like as far as West Virginians and disability. So basically, 1 in 3 adults in West Virginia is considered to have a disability. And so what does that mean exactly? Well, disability for this definition is either mobility, cognition, independent living challenges, hearing, vision, and difficulty with self-care. We spend a lot of money on comorbidities. And if you look at this, just on a dollar for dollar expense, we spend 75% of our money, our healthcare money, on these 4 chronic diseases: diabetes, heart disease, stroke, and cancer. And of those, you could look at, okay, which of these as healthcare providers can we make the biggest impact? And certainly I believe diabetes and heart disease would be up there. Cancer is, I think, a little bit harder to control. But, for us as providers, being able to interject advice and care and treatment to our patient population, diabetes, heart disease, certainly. So just to kind of back up a little bit, as far as the United States goes, nearly half of American adults do have diabetes currently or pre-diabetes. I almost think that the number is a little bit higher than what they're actually showing, because there are plenty of patients, as you guys know, that don't go to the doctor and don't get their labs regularly. So I suspect there's a lot more people wandering around that actually do have diabetes or pre-diabetes that have just never been formally diagnosed. So this just gives you an idea of how much, it's impacting our state. And then also just cost of care for people that are diabetic with an ulcer. It gets significantly more expensive by the time they get into second year, or if they've had multiple ulcers or the ulcers themselves are a little bit more advanced. They go to the ER more, they go into the hospital more, they tend to stay longer in the hospital. So overall cost of care for a diabetic with an ulcer admitted to the hospital can be quite expensive. There have been studies that have shown that integrated team management does reduce long-term amputation rates from 82 to 62%. So integrated teams definitely do make a difference and save money overall. So this is what I would consider a slightly confusing slide. There's a lot going on in this slide, but it really does give you an idea of that, what I had mentioned earlier, the head to toe complication that's related to diabetes as a disease. So I put circles around the dysfunctional part of it, and then it shows you underneath that, basically the step-by-step issues that come along with these things. So, you know, why are our diabetic patients not healing? Well, a lot of it has to do with, you know, impaired immunology. Their bodies do not fight off infection. They tend to stall out at certain stages of wound healing. You know, they develop the ulcers initially because they have decreased sensation from the nerve damage related to the diabetes. The skin becomes challenged because you know, the blood flow to the skin, the nerve damage. So there's a lot of things that are related to developing the ulcer. It's certainly very complicated. It's probably a multi-billion-dollar business just trying to figure all this stuff out. And as I mentioned earlier, you know, our goal is to try to get ahead of the curve. And in my mind, you know, trying to get these patients in before they even develop anything and having this discussion about, you know, taking care of your feet, looking at your skin, making sure that your shoes are fitting well, and trying to avoid the development of the ulcer completely is really the next best step. Did my screen just turn off?
No, we still.
No.
Fine.
Okay.
Oh.
It's showing me that something's going on. I apologize.
Something just went blank, right?
Yeah, now it went blank a little bit.
Hold on. Let's see. This is what happens when you use a tablet with very little battery life. Hold on. I'm coming.
Do you want me to try to run your slides for you so you can just kind of talk over that?
Yeah, hold on a minute. I think it should. It should turn back on in a second.
I do have your slides on my end if you did need me to share screen.
Yeah, if you want to go ahead and just pop those, you might have to tell me what the slide is. I apologize, guys. I don't know what's going on.
No worries at all. That's what I'm here for, to help with any tech issues that may arise. Okay, are you able to see that okay? And I'll just advance to where you left off.
I can't see it, but I'm going to try to log in on my cell phone. But you go ahead and pull it up for a second, and I'm going to get to my. Let's see. Where'd that go? What's the screen on it now?
I still have it on the first slide, but I can advance to where you left off.
Yeah, that would be great. Thank you.
Sure.
So I think it's my slide with my little circles on it. While I'm doing this, does anyone have any questions as of right now?
I'll monitor the chat for you, but everyone's welcome to unmute as well.
Great, I see that. Are you okay with the audio that I have right now?
Yep, we can hear you perfectly well.
Perfect, okay. All right. So next slide. Okay. So this is the most current statistics regarding amputation rate by age group. And I like this one because I think it really gives you a nice visual based on age range, but also on the next slide will be level of amputation. And you'll see that most of the patients that we tend to do amputations on run, you know, the highest group will be the 45 to 64, and then 65 to 84 age group. But we still do a fair amount of amputations on 18 to 44-year-olds. So again, I think the earlier the better when it comes to being able to see these patients and you know, get them established, see them on a regular basis. Definitely important. Next slide. And on this one, you'll see as well, the vast majority of amputations that we tend to do are toes. Then you'll see partial foot, or what they'll call transmetatarsal amputations, or TMAs. And then it'll kind of flatline at foot and malleoli and then go back up to below the knee. It'll flat out again at knee and then above the knee. And this makes complete sense from a medical standpoint, because there are certain levels of amputations that are more commonly done. It is not common anymore to disarticulate the foot at the level of the ankle for a couple of reasons. Number one, it makes it very difficult to fit them for a prosthetic, a lot harder than if you were to put them in a prosthetic in a below the knee level. The blood flow would be much better below the knee, and also just soft tissue coverage. So if you were to disarticulate the foot at the level of the ankle, there's not like, you know, a muscle flap or any kind of beefy fat layer to be able to really cover that amputation and decrease future ulceration. And that's why you see this sort of division of levels. Hip disarticulations and hindquarter disarticulations are actually pretty rare. You don't see that a lot unless somebody has a really, really severe infection and they're literally just trying to save their life, kind of thing. Or they had a horrible car accident or something like that. So just to give you an idea. So vast majority of amputation levels in West Virginia is still probably at the level of toe. And then number two would be below the knee. Next. And this is something, a visual on what basically we do with a monofilament exam. But a basic diabetic foot exam for me here in clinic would be to go over a full history, look at their comorbidities. I'm certainly looking for certain things. So cardiovascular disease, peripheral vascular disease, have they had any previous foot surgeries, amputations? Are they on a blood thinner? Why are they on a blood thinner? So if I see someone that has, let's say, for example, cardiovascular disease, they've already had 3 or 4 stents placed and they're on a blood thinner, I know that that vascular disease isn't strictly related to the heart. They have vascular disease all over. And so, you know, things like that makes them a little bit more high risk to me. I look at their hemoglobin A1C, which gives me a much better idea of how well controlled they are over a period of time. What medications they're on. Are they on insulin, or are they just on an oral? Do they have a long-wear glucometer, which I think is phenomenal. I wish everyone could have them. Unfortunately, not everyone's insurance covers them. But I think it's a game changer if you can get your patients on a long-wear glucometer. And then as far as the foot exam goes, you know, I'm checking their pulses. I'm looking at the quality of their skin. Have they had amputations? What do they have hair growth? It seems really minor, but that actually is important. Do they have muscular control? Do they have any tendon imbalances? Do they have any high pressure point areas, which might early on look like just a diffuse callus? Do they have any discoloration under the skin, which could indicate a possible pre-ulcerative lesion? So those are all the things that we go over. And I also talk about lifestyle. So, you know, I will sometimes spring a surprise question would be, besides your medication, what else are you doing to control your diabetes? And this tends to be pretty surprising for some people. And I am not surprised at all that a lot of people will say nothing. So other than their medication, they do nothing to control their diabetes. The expectation is that their medication will do everything for them. And as you guys know, that's really not the case. So, you know, frequently I'll have discussions about lifestyle choices, diet, exercise. I talk about, you know, their support system. Do they have someone at their home that is helping them, you know, cook and do things like that? I think probably one of my big challenges for patients would be in that age group where you saw the amputation level, if they live alone and they don't have a support system, either a partner, a spouse, or a family member that lives close to them, I think those patients tend to be the biggest challenges. Yeah, so definitely something there. Next slide. Okay, so usually in a hospital, you'll see the Wagner system used a lot for wound classifications. And it's probably the most common thing that you'll see on a chart as far as a wound classification. Something that we've developed specific to, well, it started in podiatric medicine, but has expanded out, would be the UT system of classification. And I like this one a little bit better because it's a little bit more specific than just the Wagner. Next slide. And you'll see it here. So it's a lot more specific to level of wound. Not only that, but also presence or absence of infection and ischemia. So this, I think, gives you a lot more detail regarding the wound itself, especially as it relates to ischemia. If you have a patient that has an ischemic appearing wound, automatically I'm thinking about vascular intervention, or at least a consult from the vascular surgery department to be able to evaluate this patient. Next slide. Okay. So some of the other things that we use here and are advanced wound therapies. One of the newest things is, and this looks very, I would say, unimpressive. It looks like a piece of, I don't know, paper towel. This is a collagen matrix that has been also impregnated with a chemical called polyhexamethylene biguanide. And that addition alone makes it harder for bacteria to form a biofilm on top of the wound with the addition of this collagen matrix. So it's really intriguing. It's something that we've been using, and I believe Dr. Diamond also has it available in her wound care center. And it's kind of an amazing, thing. Like I said, it looks very unimpressive, but something that we do have the ability to place on patients' wounds here at Ruby. Next slide. This is also another type of wound debridement tool that we use here. This machine actually cleans by ultrasonic cavitation. So it's much more precise than using a pulse lavage machine. So it doesn't just rely on volume and pressure. It actually cleans much more precisely. We have all these various tips. It's a very cool machine. And actually we can switch the tip out to a bone blade, and they use it also in spine surgery here. Next slide. This is also another product that we use here at Ruby, which is a split thickness donated human graft. So it is living when it's donated. And I really love this product because, we frequently have patients that are not healthy enough to donate their own skin, which you would be harvesting from another part of their body. So, if you think, well, gosh, if they're having a hard time, healing an area on their foot, do I really want to give them another wound, let's say on their anterior thigh, to get a split thickness skin graft? So we do have the ability to be able to place a split thickness human allograft, is what you would call that, onto a wound without having to harvest from that patient themselves. Next slide. And then this is another one, which I really like. So this is a skin closure system called the zip tie. It allows me to actually close incisions without placing sutures on top of the skin edges. This is especially important for someone who has vasculopathy or peripheral vascular disease, because sometimes the sutures can sort of clamp down on the skin edges and potentially close off maybe blood flow or the little amount of blood flow they have left. So I'm able to close skin without clamping down on any of the skin edges. This particular patient, this is a transmetatarsal amputation that I closed using just the zip tie skin closure system. And the person that was representing this product was very nervous about this, but I promise it actually healed very well. And Yeah, no problems with that. Next slide. So when do you want to refer to podiatric medicine and surgery? Well, if the patient's newly diabetic and you're just trying to establish them, if they have some type of new diabetic ulcer or wound that you want to just get a second opinion or establish for that as well. Certainly any type of lower extremity traumatic injury, a worsening infection despite adequate antibiotics and wound care. So you've already been following them. You've thrown everything at it. It just seems to stall out and you just want to get a second opinion. Certainly feel free to consult us. Need for possible surgery or a surgical consultation. I believe all of the podiatrists that are involved in this program are all surgically trained. So I would choose someone that's, close to the patient's home and refer. It's not a problem. Any kind of custom bracing, diabetic shoe, Arizona brace, anything like that, or a patient that might have neuropathic pain, specifically if they have not been in, that pain is not improved with orals such as Neurontin, gabapentin, Lyrica, things like that. We're happy to see them as well. Next slide. This is an example of a handout that we give to our new diabetic patients on their first exam or visit. And you'll see we like to use graphs or graphics. And the wording is very simplified and we try to keep it as not complicated as possible. And a lot of it is, what I specifically reiterate is they are not to walk barefoot inside or outside the home, and that socks do not count as shoes. They need to have a pair of indoor slippers with a sole, always socks and shoes when they're outside. They can safely take care of their feet. Examine their feet every day. If they're not able to bend over and look at the bottom of their feet, they can either use a long-handled mirror or just take a wall mirror off the wall, tip it against the wall, and sit in a chair in front of it to be able to examine it. Like I said, I mean, in a perfect world, there would be somebody for this person helping them, but sometimes that's not the case. And so most of the instructions that we give our patients are really things that they can do for themselves. Next slide. So this tends to be very common questions, and any of my colleagues correct me if I'm wrong. But I've had a lot of patients ask these same questions continuously. So they're newly diagnosed as a diabetic and they assume that just being a diabetic alone will qualify them for diabetic shoes. And that is actually not the case. Most of the specifics related to qualifying for certain care or appliances such as a diabetic shoe is covered under Medicare guidelines. So you could look up what Medicare covers, and most insurance companies kind of follow Medicare guideline. So they're looking for diabetic with peripheral neuropathy, pre-ulcerative calluses, acquired deformity, history of the amputation, things that make them a little bit more high risk. Now that I'm a diabetic, does that mean that my insurance will pay for custom orthotics? Again, that's generally not true. They have to have a specific reason other than just diabetes. So diabetes alone does not qualify them for much, unfortunately. My doctor and or nurse and or provider told me that since I'm a diabetic, I'm not allowed to cut my nails anymore. Again, that is not true. Medicare guideline again. So they're looking for some type of complex vasculopathy, peripheral neuropathy, chronic anticoagulation, something that makes them more high risk to do it for themselves, because we're actually billing it to the insurance as a procedure. So yeah, that would be another really common one that's asked. Next slide.
Hey, do I send too many patients to you guys to cut the nails? Because I don't think I think I send almost all of my diabetic patients that come to me.
It's all a matter of qualifying. Yeah, I mean, here at Ruby, our clinics are so packed out. I mean, they're not probably going to be seen as often. But if they qualify from an insurance standpoint, that's really the thing. Yeah. Okay, so I wanted to throw in a little bit of a foot mystery, and this is actually an actual patient that I've had. He was a 48-year-old Caucasian male, history of uncontrolled type 1 diabetes. So you'll see this was the last one I had, he was 10.1, so definitely not at goal. So from a podiatry surgical standpoint, I am offering elective surgeries to people that are 7.0 hemoglobin or less. So certainly not perfect, but that's sort of the cutoff point for risks related to surgery. Okay, so as an uncontrolled diabetic, having a surgery, increased risk of secondary infection, delayed healing, or dehiscence. I don't generally offer. Now, certainly there's certain situations where they have to have the surgery. So you do that, but as part of the consent form, I list, and I'm very specific about risks related to having uncontrolled diabetes as it relates to recovery and, complications for the surgery. So substance abuse issues, he's had history of IVDU, hepatitis C, CAD, he's had CABG, cardiac stents, AFib, history of DVT with an IVC filter, and then he subsequently ended up with a right TMA in 2019. So for 48 years old, he had a lot of stuff, a lot of comorbidities. In 1 year, he was hospitalized 12 times, which is, I don't know if that's a record or not, but and then this is a list of most of the reasons why he was hospitalized. So just a lot of different things. And then every time he would come in, I would kind of look at him and try to figure out, why is this foot still looking the way it does? Next slide. So this is his right TMA site. And every time he would come into the hospital, they would do a consult for us to look at his foot. And, the concern was always that the TMA was breaking down, he was developing wounds and things like that. And, it was just a mystery to me. We would do multiple vascular tests on him. Nothing would jump out. Double check everything, could never figure it out. And then I finally had the bright idea to stop looking for zebras and looked around to check what his shoe looked like. And he wore non-diabetic shoes. So they were very fashionable, but non-diabetic. And I thought, I'm going to look inside his shoe. Well, what he had been doing was stuffing an athletic sock into the front of his right shoe in order to be able to fit his foot into it without the foot sliding around. But because he's significantly neuropathic, he could not feel the front of his foot. So he couldn't even probably not even tell me where the sock ended and his foot started. So he was basically continuously ulcerating his own foot because he had this athletic sock jammed into the front of his shoe to be able to continue to wear his fashion shoes. And that's really where the ulceration came from. It had nothing to do with his vasculopathy or anything. His diabetes and neuropathy contributed to it, but the solution was a lot more simple than what I would work him up for every time he came into the hospital. So sometimes I think simplest is best, look at the basic things and then start looking for, like I said, look for the zebras when you run out of all other options. But, that's probably something that I learned is, you look at the basic stuff, you ask basic questions, and if you still can't find an answer, then you start looking at the more complex things. Next slide. Okay, and certainly integrated care teams. We have tons of specialty teams here. I just did a lecture for geriatric medicine. I didn't even know we had a fellowship here, but we do. We have a diabetes education center here. Patients do not even have to have insurance in order to be to attend any of the diabetes education. I'll even tell them to bring their friends that don't have insurance if they have a friend that's a diabetic and just wants to come along. We have endocrinology. We have, of course, podiatric medicine and surgery, vascular surgery, primary internal medicine. We have our wound care team and also pain management. So a lot of people don't realize if you have a patient that has failed 2 orals for neuropathic pain, there is a new implantable FDA approved device specifically for intractable lower extremity neuropathic pain that has failed orals. And we do have a program for that, specifically through Dr. Vagliani, who is the chair's program, pain management. So we have a lot of options, a lot of things to be able to offer patients. It's just a matter of getting them referred correctly. and being seen by the right specialist initially, I think, to be able to kind of hone into what is needed for them. Next slide. Okay, so this has actually changed since I put this slide together. Currently, as of 3 weeks ago, this was correct. But I just visited Kaiser, West Virginia a week ago and found out that we actually have 4 more providers that are on this list. But this gives you an idea of where you can find podiatric medicine and surgery. We also have a new provider in Kaiser, West Virginia. We have a new provider in Garrett. And we also have 2 new providers in Thomas, West Virginia. That's my understanding. Yep. Next slide. Any questions?
Thank you so much, Dr. Bozia, first and foremost, for presenting for us today and sharing your expertise with the group. But yeah, I'll open it up for any questions, comments from anyone, and I'll keep an eye out on the chat for you. Hey, Dr. Misra, go ahead. I see you raised your hand.
Yeah, thank you, Catherine, for a wonderful presentation. I am a health disparities researcher with a focus on diabetes, chronic wound. When I was at Ohio State, I, looked, they had 2 chronic wound centers where they would aggressively treat. So when you talked about lifestyle, that piqued my interest since I do self-management education for people with diabetes. Question for you, do you run their pre-albumin levels for any nutrition consult or diabetes education consult?
That's a good question. And I actually don't typically do that, but it is, I think it's a valid lab to run. If you ask a dietitian, I think they have a different opinion about nutrition level. But if I'm going to do a surgery on somebody, I think it is important to find out what their protein status is, pre-albumin and albumin, especially for somebody who is on dialysis. They always tend to be very chronically low, and just really have a hard time, I think, with healing because they just don't have the reserves. But if I do a pre-albumin and I do see that they're low, I almost always ask for a nutrition consult to try to optimize them from a nutritional intake and try to get them even those supplemental shakes to try to optimize them as much as possible.
That's wonderful. One follow-up question. Do you look at, I know inflammatory markers, you had that big slide with a lot of those, impaired immunity and neuropathy and all that. C-reactive protein seems to be the most common, but I know you had listed a lot of ILs and TNF alpha and other things. So is that something that is typically run as inflammatory markers?
Most of those advanced inflammatory markers are usually done more on a research level, but
Okay.
typically when I'm doing labs, I do CBC with differential, ESR, and CRP, because one is an acute inflammatory marker and one shows a little bit more of a chronicity. But yeah, those, and I think a protein would be absolutely valid as just even a standard for if I'm seeing a new patient and I'm planning on maybe doing surgery. Yeah, or if they stall out, if they have this chronic problem and they just don't seem to be getting any better, that's when I start doing more advanced labs, because unfortunately, based on people's insurance status, sometimes I know that they're going to have to pay a copay on their labs. So I try not to overly order too many labs if I'm seeing them on an outpatient basis, unless I really feel like they need it.
Thank you.
Thank you for those questions, Dr. Misra. Any other questions, comments from the group? We are a little over the time, but I don't want to rush anyone in case there are other questions. Dr. Mintz?
Oh, no, I just thought this was a fantastic presentation. Thank you so much Catherine, for that. And does anybody, since you've heard a lot from me about foot exams and when to refer to podiatry and all that kind of stuff, from the PCP perspective, is there any dissonance? Like, are you doing stuff that maybe isn't aligning with what Dr. Bozio is talking about based on what I told you to do? Or does this all kind of make sense? Is it, did I tell you right, I guess is the question.
Nothing really jumped out to me that was out of sync.
Like, I think the orthotics, because one of the big things that has happened is we found an orthotist to come to these clinics, which he comes up from Greenbrier. And we've been getting a lot of diabetic shoe prescriptions. But I think the majority of those are patients that do have neuropathy.
Yeah, again, it's really based on whatever the Medicare guideline is, and there's a form that has to be filled out by the MDDO. In fact, it can't be signed by an NP or a PA, attesting to the fact that the patient has more, other diagnoses other than just diabetes. I know
Yes.
WVU is in collaboration with an insurance company called Peak Health. And I tried to make a really good argument for the fact that, in my mind, if you can start them with a supportive shoe and a good insert early on, that could avoid a lot of future issues, including money expenditure. But that's just not the way the insurance companies think of it. They want to see something go kablooey first and then, pay for stuff. But, I told the person that was doing Peak Health that I feel like, diabetics really should be able to qualify for at least a plastizote insert or some kind of orthotic, knowing that decreasing pressure point areas and avoiding ulceration would be like pivotal, I think. But
Well, I think our clinic staff can actually, because they figured it out pretty easily how to do this. So I don't know if our clinic folks can maybe talk about it. We provided the form so the orders could happen. And we figured out a workaround for the APP signing. I believe that Dr. Brubaker, they send it all to him to sign. But do you guys want to tell us how you figured it out? I don't know if Kayla or Quentin want to say something, or Kristen.
Kirk was pretty helpful. I'm sorry. Kirk was pretty helpful. He kind of already had the layout of everything for the order form and just kind of said, your previous or your past note needs to say this, so that way we can get the insurance to pay for it. And then you have to have the MD or DO signature on the order forms that he provided us. So other than
Maybe
that,
more, partnering with the orthotist then might be really the way to streamline this for clinics, because they are definitely more motivated to make sure things get paid for.
Yeah.
Okay. Anyone else? I know we're going over. Sorry.
Yeah. Diabetic shoes paid out of pocket are quite expensive.
Yes. That was a big feedback that the patients, they're not going to pay for it. So that's how we figured it out.
Yeah. Do most people know that if they do qualify, they qualify for one pair a year? So if
I think Kirk has, sorry, I think Kirk has talked with them about it when he meets them. So
Thank you all so much for such a wonderful session. I know Kristen had to hop off for another meeting, but I wanted to give a shout out to both Kristen and Dr. Bozia for the case presentation and didactic today. We so appreciate you both, along with all of you joining with the comments and questions and discussions. So thank you all so much. My only announcement for today is that the next session will be on October 17th. And Dr. Meeser, we have you down to present on behavioral tools for the primary care provider. So keep an eye out for that reminder. Thank you all so much. I hope you have a wonderful rest of your day and week ahead of you. Thank you. Take care.